Okay, so can you guys see my screen?
Yes, Alanud, we
Yes,
do.
clear, yeah.
Okay, so good morning, everyone. My name is Al Abdelhadi, and my presentation is about hydrocephalus. So starting with our objectives for this presentation, we're going to understand what hydrocephalus is. So we're going to start with the definition, reviewing a little bit of the anatomy and physiology to further understand it, the epidemiology, etiology, and pathophysiology, the clinical features, diagnosis, treatment, prognosis, and a case study, and then questions in the end. So for my presentation, I fully believe that to understand the topic of hydrocephalus in the clinical presentation, I have involved the clinical scenario that we will use throughout the presentation to try to relate it to the findings of classic presentations seen in hydrocephalus. So starting with part 1 of the clinical scenario, does anyone want to read this part?
I will read it.
Okay, go ahead.
A clinical scenario part 1. A 12-week old female infant present to the emergency department with progressive vomiting, lethargy, and difficulty feeding over the past 2 days. Her mother reports that the infant has been increasingly irritable in the last week and does not appear to be herself. She has been less interactive and her cry has become more high-pitched and weak. She hasn't been breastfeeding well. Additionally, her mother is concerned because she thinks her infant head has grown and the soft spot on her head appears fuller.
Okay, thank you so much, Osama. So I have underlined the important parts that are in this scenario, which are related to hydrocephalus. So first, when we look at the age of the patient, it's very important, especially if we want to decide which investigation or imaging modality we want to use. Now, second, for the symptoms the patient's presented with, in this scenario, she had progressive vomiting, lethargy, and difficulty breathing. Now, for vomiting specifically in pediatric patients, it's very important to check the central nervous system as it could be the cause of the vomiting. And also, the patient presented with increased irritability. This increased irritability in pediatric patients can be due to any pain, which includes headaches that are seen in hydrocephalus. And also, another important thing in this scenario is the mother's description. She mentioned that the infant's head has grown and the soft spot on her head appears fuller. Now, these are some of the common presentations that are seen in hydrocephalus cases, which we'll be discussing more in the upcoming slides. Now, starting with the definition, so what is hydrocephalus? Hydrocephalus is when you have an abnormal enlargement that is found in the cerebral ventricles or the subarachnoid space, and it's caused by an accumulation of cerebrospinal fluid. Now, to further understand how hydrocephalus occurs, I will just briefly review the anatomy and physiology of the central nervous system, the CSF, and the flow and the production. Now, first, for the ventricular system, in general, it consists of 4 cavities that are connected to one another in the brain. So we have the 2 lateral ventricles, and these are the largest out of all the ventricles. Then we have the 3rd ventricle and the 4th ventricle. So these ventricles are a part of the CSF production and also the circulation. CSF will be produced in the choroid plexus that are seen in the lateral, 3rd, and 4th ventricle by plasma filtration. And after it being produced, the flow starts in the lateral ventricles. As you can see here, I labeled them in the picture. So in the lateral ventricles, and then from the lateral ventricles to the 3rd ventricle by the interventricular foramina of Monro. And then from the 3rd ventricles into the 4th ventricle by the cerebral aqueduct, and then to the subarachnoid space by the foramina of Luschka and the foramina of Magendie. And then after that, it goes by reabsorption in the arachnoid granulations, and then it will go and drain into the dural venous sinuses. Now for the epidemiology, hydrocephalus has no sex preponderance, which means that males and females are equally affected, even in Saudi Arabia. As you can see in the small study that I found here, they mentioned that it was equally affecting males and females. Now, hydrocephalus, the communicating type, is much more common than the non-communicating type, and in 60% of cases, the diagnosis of hydrocephalus is usually congenital hydrocephalus. Now, for the etiology, hydrocephalus has 2 main types, which is the communicating and the non-communicating. Now, starting with non-communicating, by its name, Now, communicating hydrocephalus requires free communication between all the ventricles and the subarachnoid space. Basically, what happens is that as a result of dysfunction in the arachnoid granulation, you will have either decreased absorption of the CSF or increased production. So let's say there's an inflammatory process that is happening in the brain. Let's say meningitis or subarachnoid hemorrhage, among others. It will lead to fibrosis in the arachnoid granulation and scarring, and this will lead to decreased absorption and preventing the drainage in the subarachnoid space and into the venous system. Another cause of decreased absorption would be congenital absence of the arachnoid villi. And also another cause would be an increase in the production. An increase in the production would occur if there is a choroid plexus papilloma, carcinoma, or even an inflammation in the choroid plexus. So what happens here is that as a result of that, the CSF will build up, which will cause an enlargement in the ventricles, and this will lead to intracranial hypertension. So as you can see in the image here on the left, this is just a CT scan example of a patient that had a left temporal lobe hemorrhage. So when they had a left temporal lobe hemorrhage, it extended up to the subarachnoid space, and this led to ventricular dilatation, which you can see here, and also periventricular edema. Now, for the non-communicating type, as I mentioned, for the communicating type, there needs to be free communication between the ventricles. Here, in non-communicating, the opposite is true. There's going to be something that will obstruct the passage of the CSF from the ventricles to the subarachnoid space. So this leads to dilatation of the structures and then further complications. So for non-communicating, it can be congenital or it can be acquired. For the congenital causes, they occur early in infancy. It includes Arnold-Chiari malformation, Dandy-Walker malformation. Dandy-Walker malformation is basically a congenital malformation that happens in which there's a failure of the fourth ventricle to close, and this leads to persistence of the Blake's pouch and hypoplasia of the cerebellar vermis. Other congenital causes include intrauterine infections. This includes torch infections that happen that lead to scarring in the meninges, and this will impair the flow. So what happens is that these infections, as I mentioned, they lead to scarring, and this will cause narrowing of the channels in the aqueduct, and this will lead to further obstruction, leading to the obstruction of the passage of the CSF from the ventricles to the subarachnoid space. Another cause is colloid cyst. Colloid cyst can be congenital and also can be acquired. And also another congenital cause is the congenital stenosis of the cerebral aqueduct of Sylvius. And the acquired causes includes the brain tumors, which includes peniloma or even colloid cysts, which I mentioned. So the picture here on the left shows a T2 weighted MRI image. It shows hyper intense lateral ventricles, and they are severely dilated and also compressing the brain parenchyma. So now with this part and the next part, I just underlined the important parts and I will be mentioning them briefly. So in part 2, the infant had fever and she had decrease in urinary and bowel movements, which are important in the cases of hydrocephalus. And also in the third part, which is what I believe the most important part about the whole scenario, is that it explains that the patient is lethargic, her head is oddly shaped on physical examination, and also her scalp veins are prominent, and the anterior fontanelles are tense and bulging. She had a downward gaze, and this is very important because this is the setting sunset sign that is seen in pediatric patients when they have hydrocephalus. And also another important finding is the increased tone in the lower extremities and also brisk reflexes bilaterally. And also another important finding that I didn't underline is the extraocular movements are also dysconjugate. So based on that, I will just discuss briefly the clinical features that are seen in hydrocephalus. So as a result of increased intracranial pressure, the patient would have headaches. And in this scenario, as it's a pediatric patient, they will not complain of a headache, they would have irritability. Nausea and vomiting, our patient had vomiting. Papilledema, impaired consciousness, abnormal gait, and Cushing's triad. Cushing's triad is basically irregular breathing, widening pulse pressure, and bradycardia, and also abducens pulsi. Additional findings that are seen in infants includes macrocephaly, which was seen in our patient, tense fontanelles, which was seen on physical examination, setting sunset sign, which is basically the one we mentioned, that is the downward gaze that is seen in the patient, and also McEwing sign. McEwing sign is basically a sign of late hydrocephalus. This is basically when you do percussion and junction in the frontal, temporal, and parietal lobe bone, and what you hear is resonance. Now, some other things that can happen is that due to the brainstem compression that can happen with hydrocephalus, there can be changes in vitals and also lower extremity spasticity and hyperreflexia, which was seen in the patient as well. Now, for the last part, they mentioned that they had an imaging study that was done, and they did also the ventricular peritoneal shunt. The imaging modality of choice that is used is different according to the patient's age. As I mentioned in the beginning of the scenario, the patient was 12 weeks old, so this suggests that the imaging modality of choice would be an ultrasound. So as I mentioned here, for diagnosis, ultrasound is indicated if the infant is less than 6 months of age, because the anterior fontanelles are still open and you're able to see with an ultrasound. And also if there's clinical suspicion during antenatal period. The findings as seen here is going to be enlarged lateral ventricles. Now, if the patient was older than 6 months, this basically means that the fontanelles have already closed. And the diagnostic modality of choice would be an MRI or CT, but MRIs are preferred. So what you're going to see, are features of acute hydrocephalus, which includes, as seen in these pictures, enlarged ventricles, Mickey Mouse ventricles, and other findings as well. Now for the treatment, usually the treatment is by cerebral shunt, and basically what it does is that it returns the excessive CSF from the ventricles into the systemic circulation. And most commonly it's done by the peritoneum, which was seen in the patient as well. They did the ventricular peritoneal shunt. Now, some of the complications include infections. This can be by bacterial contamination, shunt malfunction, and shunt malfunction can be due to blockage that is either complete or partial. Sometimes under drainage can occur, and this can increase the intracranial pressure, or over drainage. Now, over drainage is a serious can lead to serious complications as well, because it can lead to intracranial hypotensive syndrome. And if it became chronic, it can lead to slit ventricle syndrome. So what is slit ventricle syndrome? Slit ventricle syndrome is basically when you have collapse of the unilateral wall of the ventricles and under drainage of the contralateral walls. Now, other treatment options include diuretics, fibrinolysis, serial lumbar punctures, and acetazolamide. Now, other surgical options that can be done includes endoscopic third ventriculostomy. This one in specific is contraindicated in communicating hydrocephalus, choroid plexectomy, and cerebral aquedoplasty. This is basically opening the blocked cerebral aqueduct. Now for the prognosis, briefly, I just want to mention that prognosis improves the earlier you detect the patient with hydrocephalus and the earlier you start the treatment, and also by preventing infections. So mortality is only 5%, but in 40% of cases or 50% of cases, they usually have normal intelligence and normal lifespan. So furthermore, as I mentioned here, the prognosis is very important when it comes to preventing infections. This was a study that was done in Saudi Arabia, and it mentioned that the most common cause of the ventriculoperitoneal shunt malfunction among pediatric patients is basically following an infection. So this furthermore improves the point that the prognosis improves as the prevention of infection also occurs. And thank you. This concludes my presentation. I hope it was clear for everyone. And if you have any questions, please feel free to ask.
Any question?
No, doctor, everything's clear.
Okay, so I've added 2 questions in the end. Does anyone want to read the first question?
I can read it.
Okay, go ahead.
A 5-month-old infant is brought to the physician by his parents for the evaluation of progressive enlargement of his head circumference. His parents report that he has been healthy except for an episode of tonsillitis 3 months ago, treated with penicillin. The patient is born at term by a lower segment transverse cesarean section because of a transverse line. He has met all his development milestones. His immunizations are up to date. The patient is at 50th percentile for length, 50th percentile for weight, and 95th percentile for head circumference. He appears well nourished. His temperature is 37 degrees, pulse is 120, and blood pressure is 90 to 60. Physical examination shows a tense anterior fontanelle. The eyes are deviated inferiorly and the eyelids are retracted. Which of the following is most appropriate next step in diagnosis? I think you should do a ultrasound of the head.
Yes, exactly. So as mentioned in this, thank you, Ala. As mentioned in this scenario, the patient was 5 months old. So this means that they're less than 6 months, and the first modality of choice would be an ultrasound. Thank you so much. And the next question, who wants to read it?
Okay, I would read it.
Go ahead.
Second question. A 2-year-old boy is brought to the physician by his parents. Several weeks after the family immigrated from Russia, the parents are worried because the child appears to have a trouble seeing and hasn't started walking. The child was born at home, and he never been evaluated by a physician. During the pregnancy, the mother had a week of fever, myalgia, diffuse rash, and bilateral non-tender cervical adenopathy. After the family adopted a new cat, an MRI of the head is shown. Which of the following additional finding would be most likely in this patient? So we have A, continuous machinery murmur. B, pupils doesn't react to light but constrict when with accommodation. C, spasticity of bilateral lower limb extremity. D, tuft of hair over the lumbosacral area. And E, loss of pain sensation in shoal distribution. So the answer here would be C, the spasticity of bilateral lower limb edema, because we have I think the Mickey Mouse appearance on the MRI.
Yes, thank you so much, Sama. And as he mentioned, the spasticity of the bilateral lower extremities is the common finding that is seen. And I just wanted to mention that they mentioned here that the mother had a week of fever, myalgia, diffuse rash, bilateral, non-tender cervical adenopathies. This can lead to us thinking that maybe there was complications in the pregnancy, which led to torsion infections. And these are the references, and thank you, everyone. If you have any questions.
Thank you, Lanud. Any question?
No, doctor, everything is clear.
Yeah, okay. The presentation is very comprehensive. So, but just to add 2 practical points. One is one of the modality of treating an obstructive type of hydrocephalus, as Lanud mentioned, which is they call it third ventriculostomy. Third ventriculostomy, where the neurosurgeon go through the close to the location of the anterior fontanelle, they open and they go by scope to the third ventricle, and at the base of the third ventricle, he just made a hole. So the CSF will flow to the fourth ventricle, and this will eliminate the need for ventriculoperitoneal shunt, because ventriculoperitoneal shunt is not assemble. It's like having a hose below the skin throughout the life, with the risk of complication is very irritating and make the family and the parents anxious. So this procedure is limited to the obstructive type. The other type doesn't usually help. It's commonly done in adults, sometimes in pediatrics. When you are an emergency room, when you receive a child who is having hydrocephalus with VB shunt, and he present with decreased level of consciousness, seizures, fever, or mix of these symptoms, then you have to think about the VB shunt complication, which is mainly infection, malfunction, or immigration of the shunt. So if there is any effect on the flow of the CSF, that can lead to increase intracranial pressure and then lead to decreased level of consciousness or leading of seizures. This is the commonest presented. This is why in emergency room, when those patients present with this scenario, they call usually the neurosurgeon. They don't call the pediatrician to clear him. Once he's cleared that his symptoms is not related to the shunt problem, then pediatrician can be involved on the management. Okay. If you don't have any question, we will conclude my session.
يعطيكم العافية دكتور. Everything is
Allah
clear.
يعافيكم. I wish you a good, nice day.
Thank you.
Same to you, doctor.
شكرا.
اوكي، السلام عليكم. يعطيك العافيه دكتور عبد الله.
وعليكم السلام ورحمة الله وبركاته.
وعليكم السلام دكتور.
Are we starting now?
Yes, doctor. Good morning.
السلام عليكم. هلا. Good morning.
Alaikum salam. I'm Malik, who I believe I'll be going first, and then my colleague Alauddin would present after me.
Okay, go ahead.
Is my voice clear?
Yes, it's clear to me.
Yes, Muhammad is clear.
All right, thank you. Can you see my screen?
Yes, we can see it.
Yes.
All right, so good morning, everyone. My name is Muhammad Malik Al-Masri, and today I'll be presenting a lecture or the topic of pediatric ARDS, which is pediatric acute respiratory distress syndrome. These are going to be our objectives for my lecture. We're going to define it, and we're going to go over some of its etiologies, have a look at the pathophysiology, how they're going to present clinically, go over some treatment methods, and talk about the complications and prognosis. Now, we need to understand its definition well so we can know how to differentiate it and identify it whenever we come across it. Now, the pediatric definition is basically a modified definition of the adult ARDS. And the adult definition is about it's an acute diffuse inflammatory lung injury, which leads to increased pulmonary vascular permeability, extra lung weight, and loss of aeration of the lung tissue, with hypoxemia and bilateral X-ray or radiographic opacities. You're going to also have increased physiological dead space and decreased lung compliance. In pediatrics, the definition and it also assesses severity. So it also both defines it and assesses severity to go with different treatment modalities. It should be timed within 7 days of a known clinical insult. The respiratory failure should not be fully explained by cardiac failure or fluid overload. Chest imaging findings of new infiltrates should be consistent with acute pulmonary parenchymal disease, and there should be an impairment in oxygenation. Now, this table is taken directly from Nelson's Essentials of Pediatrics. We have two types of PARDS. One of them is the non-invasive and the other requires invasive mechanical ventilation, depending on the severity. We need to calculate two ratios, or like one is enough if the other isn't available. The PF ratio, which is the partial pressure of oxygen to the flow of inhaled oxygen. If it's less than 300, we need to apply a full face mask with positive airway pressure on both sides, above 5 degrees of water, or in units of pressure. If the partial pressure of oxygen is not available, we're going to have to move on to the saturation flow ratio, which should be less than 264 for a full face mask. But in case of invasive mechanical ventilation, we need to measure the severity using the oxygenation index or the oxygen saturation index, which follows the same concept of the PF and SF ratios, but in terms of the flow multiplied by the mean airway pressure multiplied by 100 divided by the partial pressure of oxygen. Or in the case of OSI, we just replace the PaO2 with the saturation percentage of oxygen. Mild is between 4 and 8 for the oxygenation index. Moderate is between 8 and 16. And severe is when it's above 16. Now, some of the investigations we'd like to consider, because PARDS can be mixed with like
Just can we add a comment here? Like in general, what does these ratios means in terms of severity?
In terms of severity,
what does it tell you? Like pathophysiologically, what does it tell you?
Lung function is deteriorating, and the patient or the child is not able to fully oxygenate their body.
So, based on the definition, you mentioned the pathophysiology that's happening is increasing permeability, and this permeability causing influx of fluids into the lungs, and this influx of fluids, where does it go?
It stays on the diffusion membrane, from the alveolar side, where like the oxygen should be.
So it either goes into the alveoli and then that block area for ventilation, or it goes into the interstitial space. Regardless where it is, it does increase the space, the distance between the blood vessel that takes the oxygen and the air. So the distance will be higher, and then there will be less space or less surface membrane for the diffusion or the gas exchange. So it's just about blockage of the gas exchange that happens. Mainly we're talking about oxygen here in ARDS. So, and then when you go into these ratios, when you look at the ratios in general, regardless whether you're measuring it using the ABG or you're measuring it using the oxygen saturation through the probe, it's about how much you give oxygen and then how much of the oxygen actually end up into your blood. Because you divide these ratios in different ways, whether you took it from the blood gas or from the saturation. And the more you give oxygen and the saturation is static, the more severe. And this is just the main idea of knowing the severity of the ARDS in general. And if you add again the other criteria of being generalized, not related to one specific disease and all that, but that's the main characteristic that we all, if we want to grasp something from this lecture, is that it's a diffuse blockage of the gas exchange that happens because of influx of fluid. Okay, keep on.
All right, thank you, doctor. Moving on to some of the investigations we'd like to order to either rule it in or rule it out. An X-ray of the chest, because as we mentioned, if we find new onset bilateral opacities, or we can move on to CT of the chest in case that the X-ray findings were inconclusive, a lung ultrasound to be able to differentiate between ARDS and cardiogenic pulmonary edema, ABGs to check for the respiratory alkalosis or the PaO2, CBC to check for leukocytosis in either sepsis or pneumonia. We'll touch on that in the upcoming slides. Lipase to check if it's due to pancreatitis or to try and rule out pancreatitis. Blood cultures to identify the causative bacteria if in case it was bacteremia. And sputum gram stain and culture to identify the bacterial pneumonia. Now, as for etiology, PARDS can be triggered by many insults, including sepsis, pneumonia, shock, burns, or traumatic injury, which all result in inflammation and increased vascular permeability, leading to pulmonary edema. Now, there are many mediators of inflammation that are involved, and one of the things that can also be involved in PARDS would be surfactant. Now, I found this, I took this line from one article in PubMed. It was a study conducted in Saudi Arabia about the effects of PARDS on neonates. It was the most related one I could find. It was just saying that between like infants with PARDS and infants without it, the ones who had it had significantly lower birth weight and had lower APGAR scores at minutes 1 and 5 after birth. So it's a very crucial condition to try and identify and fix as soon as possible. And PARDS doesn't really, it's not as common in pediatrics, especially like in ICU admissions, but it is very difficult to like try and tackle and treat quickly. The main causes are pneumonia, which accounts for 35%, aspiration, 15%, sepsis, 13%, near drowning, 9%, concomitant cardiac disease, 7%, and other clinical conditions were 21%. Infectious etiologies, including sepsis and pneumonia, are almost half of these clinical conditions. Now, as for the pathophysiology, the doctor mentioned that inflammation or sepsis would cause endothelial cell dysfunction, fluid would leak from the capillaries and impaired drainage of fluid from the lungs. After that happens, you're gonna need more inspired oxygen and higher concentrations to try and oxygenate your body. And what would happen next would be called a respiratory burst in immune cells, which is basically when they release superoxide and all the reactive oxygen species, which would cause an inflammatory reaction. And in the secondary phase, the endothelial cell dysfunction would cause inflammatory exudate to enter the alveoli. The pulmonary edema would increase the layer, the thickness of the layer separating the blood in the capillary from the air in the air sacs. Increasing the distance oxygen needs to diffuse, and that would impair gas exchange, leading to hypoxia, increased work of breathing, and eventually scarring of air sacs and the lung. The second part of the pathophysiology is related to the volume of air in the lungs, basically. As as you lose aeration of the lung and the disease progresses, the end tidal volume becomes incompatible with life because the oxygen is there, but it's barely providing anything to the body. So the muscles of the respiration become fatigued due to the constant heavy load of breathing, trying to compensate for the ARDS. At this point, we need to initiate or start mechanical ventilation. But mechanical ventilation isn't always a good thing because it has risk factors. Among ventilator-associated pneumonia, there's also the very common barotrauma due to the positive airway pressure. And barotrauma is when you injure the lungs due to increased pressure, especially because these patients get to a point where they can't breathe on their own. Now, as for clinical presentation, hypoxemia, bilateral opacities on X-ray, decreased lung compliance, and an increase in physiological dead space are all going to be seen in PARDS and need to be properly managed. There are early signs, which include tachypnea, tachycardia, in an attempt by the patient to improve their minute ventilation and cardiac output so they can maintain oxygen delivery to tissues. And as the disease progresses, it may result in dyspnea, nasal flaring, grunting, usage of accessory muscles, of respiration, and diaphoresis, which is excessive sweating. Late signs include cyanosis, altered mental status, which starts as confusion, then moves to agitation. And you're going to see signs and symptoms of hypercarbic respiratory failure. And in attempts to increase minute ventilation, again, tachypnea, and they're going to have deep breathing. And it progresses to altered mental status in terms of somnolence, or when they become sleepy. Now, for treatment, we need to address the hypoxemia, apply lung protective ventilations, which we'll discuss, and we need to identify and treat the underlying cause. Lung protective ventilation. Patients with ARDS need lung protective ventilation so we can avoid the barotrauma we mentioned earlier. And there are settings we can apply to the ventilator, which includes a low tidal volume between 6 to 8 milliliters per kg to prevent alveolar distension, a low plateau pressure of less than 30 centimeters of water to avoid the barotrauma, and a positive and expiratory pressure of more than 5 centimeters water to allow alveolar recruitment, but not to the point where it distends them and may cause damage. And we need to do something which is allowing permissive hypercapnia. And hypercapnia is when the partial pressure of carbon dioxide is above 45 millimeters. And usually this is something that needs to be treated. But in case of pediatric ARDS, we need to allow it to happen to protect the lung. Now, the PEEP and the flow of inhaled oxygen can be adjusted to recruit collapsed alveoli and better the oxygenation. Our goal would be to reach a partial pressure of oxygen between 55 to 80 millimeters of mercury, or a saturation of 88 to 95%. And to avoid oxygen toxicity, we try to use the lowest flow oxygen that we can. Prone positioning is when we put the baby on, or the child on their stomach. It reduces the ventilation perfusion mismatch due to dependent atelectasis, because usually they're lying down. And this also helps increase lung compliance. Indicated when the PF ratio is less than 150, or in the presence of pulmonary edema. Lung recruitment maneuvers, it includes the sustained inflation techniques, where you have an increase in airway pressure for a few seconds and then you decrease it, so you can keep the lung inflated in a way. Or we can implement the incremental or gradual PEEP increase. Supportive care, of course, we need to apply conservative fluid management and consider furosemide or diuretics for any volume overload. Venous thromboembolism prophylaxis, such as compression socks, early remobilization, if they're going to be bedridden for a while. Optimize their nutrition, either enteral feeding or oral if they can take it. Consider stress ulcer prophylaxis with H2 blockers or PPIs. Complications and prognosis. Usually patients improve after 1 to 3 weeks and symptoms resolve completely. Some of them develop interstitial pulmonary fibrosis with prolonged ventilator dependence and a restrictive lung disease. Patients, unfortunately, with simultaneous multi-organ failure usually have a mortality rate between 30 to 50%. A quick overview of restrictive and lung diseases and interstitial pulmonary fibrosis. Restrictive lung diseases are characterized by an impaired ability of the lung span, usually disorders of the lung parenchyma, the pleura, and the pleural cavity, or deformities of the chest, and weaknesses in the respiratory muscles cause restrictive lung diseases. The common findings are decreased vital capacity, decreased total lung capacity, normal or decreased FEV1, and normal or increased FEV1 to FVC ratio. Now, as for interstitial pulmonary fibrosis, it's under the restrictive lung diseases, also results in reduced lung compliance. Its manifestations include progressive dyspnea, a dry cough, fatigue, and inspiratory crackles on auscultation. Now, these are two brief questions to review the presentation. Which of the following is not related to ARDS? If anyone would like to answer or type it, please go ahead.
Is it D?
Yes. Increased intracranial pressure has nothing to do with ARDS, as per the definition. Now moving on to the second question. Which of the following should be present to define and measure severity of ARDS?
A. Onset within 7 days of known clinical insult.
Yes, that is correct. It is part of the definition and assesses the severity. Thank you all for listening. If there are any questions or comments, feel free to let me know.
No questions.
Doctor?
Thank you. It's really great. And just a comment with regard of the study that has done in Saudi, the low Apgar and the low birth weight, and these are really not of a complication. It's more of the predictive or a risk factors for developing ARDS, considering the immaturity of the lung tissue. Instead of whenever you have such patients, immature patients, and you should be vigilant for other risk factor like sepsis that might lead to the ARDS in general. Really a great talk. Thank you so much. Very well comprehensive.
All right. Thank you so much, Doctor. These are my references and sources. And thank you guys for listening.
All right, so I'm next. Can everyone hear me?
Yeah.
Yes, Allah, we can hear you.
Oh no. Okay, let me find.